It is also a pleasure and a special privilege to visit such a nice and historical city, unique in the world, as Toledo. This is my conflict of interest, and today I will briefly try to make a few points. First of all, to remind that type 2 diabetes is an endocrine disease where insulin is deficient. I will also remind how important it is to replace basal insulin, how this should be done with appropriate titration, with early timing of initiation. Then I will come to some practical differences between the products that we have on the market, focusing on the most recent insulin analogs. And then I will remind that on top of insulin, in type 2 diabetes, you can compose and add on stratification of additional drug to get the targets. In type 2 diabetes, which is an exploding problem all over the world, there are many, many unmet needs, but I did pick up most of the important ones, which is aging of the population, and the elderly people, as you know, are more frail, more prone to hypoglycemia, and a lot of recent literature has actually demonstrated the association between hypoglycemia and increased cardiovascular risk. Hypoglycemia and also hyperglycemia are often responsible for frequent admissions to the hospital. And as you know, because you are clinicians working in internal medicine, you are well aware that some of these people actually have multiple re-entries in the hospital. So there are many, many aspects that we should take care of in treatment of type 2 diabetes. Well, the UK PDS study that you are familiar with has shown a fundamental observation. If you follow up new onset type 2 over the years, you can actually find it out that the endogenous insulin secretion decreases rapidly over time. And this points out that type 2 diabetes is a disease with a progressive insulin deficiency. As when you have a thyroid insufficiency or corticoadrenal insufficiency and you would replace the missing hormone, we need to replace insulin. So this is the most important message I like to deliver to you today. In the real world nowadays, insulin is initiated late. You see here geographical areas from all over the world, and these horizontal bars represent the years after onset of type 2 when insulin is initiated. On average, you see 10 to 15 years of delay in insulin initiation. And to the far right, you have these numbers. This is the glycohemoglobin value at which the patient is initiated on insulin. On average, this is above 9%, 10%. So the present situation is that insulin is initiated late after many years of very poor control, and of course it is difficult for such a late initiation of insulin to have a good prognosis for the patient. Well, that was the world. This is my country, Italy, no different. We initiate insulin when glycohemoglobin is about 9%, and actually after about 10 years of diabetes duration. So this is clinical inertia, and we need to be more active in our clinics to initiate insulin earlier. Now, what is beautiful about basal insulin is that actually when you have a patient represented here with fasting hyperglycemia and also postprandial hyperglycemia, you initiate basal insulin and you titrate this basal insulin, you lower the fasting, but you also lower the postprandial. And at the end, many patients will be at the target if you have been so good to titrate the fasting plasma glucose. And actually, this principle has been demonstrated in many studies, but I always show these very important examples of several years ago from Matt Riddle. This is the famous treat-to-target study comparing glargine U100 with NPH. And you see, regardless of the insulin you use, a titration will take the patients down to the nice 7.0% glycohemoglobin. But in order to do that, you start with 10 units of insulin, but every week you have to increase the dose because you like to lower the fasting hyperglycemia. If you don't increase the dose, if you don't titrate, if you stop from 10, if you stop to 15 or 20 units, the hyperglycemia remains and the glycohemoglobin is not coming down. So in order to have a glycohemoglobin of 7, in this study, the final dose was 45 units because these were obese type 2 patients from actually North America. And this titration allowed a good fasting plasma glucose. These are millimoles, which in milligram DL would be like 115 milligram DL about. So in practice, we have to be very simple with the titration. We have to measure the fasting blood glucose every day to take the last 3 days. And if the median is above 110, we can add 2 units. If it is 110, we keep the dose. If it is below, for safety, we reduce by 2 units. This is something very simple. Does not need a specialized doctor. A nurse can be actually involved. Even patients can do that after a small teaching. And there are several studies showing the feasibility and the effectiveness of titration on behalf of the patients. Well, basal insulin is this ideal flat line of plasma insulin over the 24 hours. This is the normal glucose homeostasis with the small excursions of glucose before and after the meals, and the very nice physiological peak insulin secretion in correspondence to meals, but also the interprandial basal insulin. An ideal basal insulin should really mimic physiology, should be characterized by very low variability, should be flexible in terms of dosing, which means that I can give it in the morning or in the evening, dinner time or bedtime, with non-important differences. And then it should be available to everybody at a sustainable price, because insulin, of course, is a life-saving drug, cannot be matter of financial speculation. Well, on the market, we are embarrassed because we have nowadays so many products. We used to have only NPH until 20 years ago, but over the last years, we have enriched the market. I will not discuss every preparation. I will focus on the most recent actually candidates, which are degludec and glargine U300. We have stopped using NPH that all doctors like myself have been using for 30 years. The reasons is that NPH is not a basal insulin, it is a peak insulin, as you see here. Also, it is very variable from one injection to another. Insulin glargine U100 and Detemir have been, of course, an improvement because they have a much less peak, as you see here in the actually violet and the green line. Remember, Detemir has a much shorter duration of action, and this is why it is not so good as compared to glargine U100. But most recently, we are more demanding in terms of quality of basal insulin. We like really to approach the physiology, and the physiology speaks for a very flat, very long-lasting basal insulin. So I will try to introduce you to these new preparations and try to highlight the advantages as compared to glargine U100 and insulin Detemir. And I will be very practical with my questions. Insulin degludec is an acylated insulin where the molecule of human insulin has been bound to a long-chain free fatty acid via a spacer of glutamic acid. The way it works, this is the story narrative told by the producing company Novo, is that after sub-Q injection, loss of phenols and subsequent loss of zinc actually forms polymers, which is responsible for delay in absorption, which subsequent dissolution into hexamers, dimers, and monomers in the blood. The second new long-acting insulin is glargine U300, which is a new insulin because it is 3 times concentrated. Interestingly, it is a very old insulin because the molecule is exactly the glargine molecule. The little trick is that this more concentrated actually glargine comes into a volume which has been reduced 3 times. So you concentrate 3 times, you actually reduce the volume by 3 times, so 1 unit should be 1 unit. However, the kinetics of absorption of the more concentrated U300 are quite different as compared to the U100 with a slower and more prolonged absorption. This is Rainer Becker, the inventor of U300 in Frankfurt, and if you ask him how it works, U300, he would give you this equation on the bottom, and if you are able to solve the equation, you will understand how the absorption kinetics of U300 actually work. Well, we are not so interested in theories, we are interested in facts. So what we did most recently was to inject U300 glargine and U100 in people with type 1 diabetes to understand the difference. This was an evening injection at 8 p.m. and every person did use his or her own dose which came from real life. So you see that after injection of a higher dose of U300, actually the plasma insulin on top in black dots was actually lower for the initial hours, but in the afternoon, later on during the day, was higher. So if you look at the line with the black dots, this is more flat as compared to the U100 glargine with an initial increase and a subsequent decrease. So this PK observation indicates that you have less risk for nocturnal hypoglycemia with the U300 and better glycemic control in the afternoon before dinner. Glucose should be better, especially if you have a late evening meal, like I'm sure you have in Spain, like in South Italy. This is the reason why we have moved all patients with type 1 diabetes from glargine U100 to glargine U300 because it is more physiological. Well, both degludec and glargine U300 have undergone many trials. The trials of degludec, the name are BEGIN studies. I'm sure you are familiar with those. The comparator has been glargine U100. On the other hand, the trials of glargine U300 are named EDITION. Again, I'm sure, I trust you are familiar with EDITION studies, and interestingly, the comparator is the same U100. So both degludec and glargine U100 have been compared to the same comparator. And it would take a long time to go through the studies, but the message is very simple. The results of the BEGIN trial and the EDITION trial are quite consistent on two conclusions. First of all, the new insulins are not more potent than glargine U100. They have the same efficacy. So if you move patients from glargine U100 to degludec or glargine 300, please do not expect a lower A1C. A1C will be the same. But these new long-acting insulin are safer, are better, should be preferable because they reduce the risk of hypoglycemia. So the progress has been better safety for patients. And in addition to that, there are nice observations with the glargine U300 in a special population. These are now renal patients, which are more and more represented in our wide variety of people with type 2 diabetes. And without going into details, you can pick up the message here that the risk reduction of hypoglycemia in renal patient is similar to people with normal renal function. So it is very important to be aware that glargine U300 is protective against hypoglycemia in this frail population. Another important and frail population is a population with the older people. Here in this study, population above 60 years of age were examined, and the message is that the risk reduction of hypoglycemia with the U300 as compared to U100 is confirmed to be preserved both in people older than 65 as compared to younger than 65. So again, new important information about cardiovascular protection of the elderly people from reduced risk of hypoglycemia. Following this post-hoc analysis in older people, a new prospective trial called Senior has been performed in more than 1,000 people, and the aim of the study was to prove the safety and efficacy of U300 in people above 65 years of age focusing also on the most elderly people above 75 years of age. And you see here the results of the incidence of hypoglycemia, which was lower in the population above the age of 75 with the U300 as compared to U100, and similar results are obtained if you look at the rate of hypoglycemia, especially the documented symptomatic hypoglycemia with a threshold either below 3.9, which is 70, or 3.0, which is 54 milligram DL. So based on this observation, the message is that when we have to do with the frail population, renal, old, elderly people, U300 looks more preferable, more attractive than U100 insulin.